Hello and welcome back to another episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland, and in this podcast we try and give you a bit of a how-to guide to help you overcome common myths, fears and barriers to cancer prevention, diagnosis, treatment and care. And in this episode we are definitely overcoming some common myths. So in this episode, we're going to talk about what happens after the bowel screening. We talked in the previous episode about the bowel screening itself. We talked about technique for providing your poo sample. And for 98%, or just over 98% of people, they'll get a letter back and saying that everything's absolutely fine. Come back in 2 years and do your test again. But for that 1.76% of people, this is 23-24 stats, who are invited back for further tests. There's at least one high-risk polyp. We found out what polyp was. We'll talk a bit more about that. What happens then? So to explain what happens next, I'm joined by Clare McGeady, who is the lead nurse at the North East London Screening Service. Hello, Clare.
Hello there. Hi, Steve.
Clare, we've just been talking, haven't we? You said that your mum used to send her screening kit back with her Christmas cards.
She did.
I hope no one got the screening kit rather than the Christmas card. That would be quite embarrassing.
It would have been very embarrassing. No one mentioned it ever receiving it, no.
Well, they wouldn't, would they?
No.
I mean, you just wouldn't hear from them again. More importantly, so, I said 1.76 of people, 1.76% of people in 23-24 were invited back for further tests. Let's go back a bit before then. You send your test off, and we talked about the techniques and everything in the first, our previous episode. You send your test off. What happens then? What's the time scale between then and getting a response? What are the options in terms of a response you'll get? What happens next?
Thanks, Steve. So within 7 days of the person sending the test kit back to the hub, and the hub is at St Mark's in northwest London, they will receive a letter. So if the test is abnormal, if there's blood detected in that sample, they will receive a letter saying your test is abnormal, and they will receive an appointment to see a nurse, a screening practitioner at one of our sites. So we work at the Homerton Hospital in Hackney, we work at Mile End, and we work at Whipps Cross Hospital. So the nurse, the SSP, we call ourselves screening practitioners. What will happen then is essentially that they will see the patient in clinic to do an assessment of that person and to talk to them about some of the reasons that might have caused that positive test result. And for the majority of people, they won't have cancer, as been said before. We talk about the reasons that could have caused the blood. And a lot of people come in and say to me, look, I've got piles. I know that's the reason for the test being positive. And I always say to people, you can have piles, but you can also have a cancer. So just because you've got one doesn't mean you haven't got the other. We talk about polyps. We talk about diverticulosis, which is a condition of the bowel. And it's kind of probably best described as wear and tear of the bowel, where if you imagine a picture of the bowel, there's little pouches along it. And if you become constipated on a regular basis, for example, you might get some blood that could show up in your test kit. So the screening practitioners see the patient in clinic and talk to them about the colonoscopy test that we want to do. And what we do is try and break it down to the patient, because a colonoscopy sounds quite scary. It's not like
absolutely terrifying.
It does, and it's not like having a regular blood test. It's much more invasive, and we have to talk to them about the pros and the cons of having it done. And often we find that as people are talking about health more, people will have heard about people that have had a colonoscopy, and they might have had some horror stories. And our job is just to talk to the patient, and we break it down. We don't use difficult terminology. We use really sort of we kind of gauge the language the patient wants to hear and to talk about. And
what sort of language what sort of language are we talking? How would you describe it to me? Because I like things in quite plain language. So how would you describe a colonoscopy to me if I was...
So a colonoscopy is when a senior doctor, a consultant, will put a very thin, flexible tube into your bottom and pass it around the whole of the large bowel, which is about 1.3 metres in length.
1.3 metres?
It is. It's quite long. It stretches. And often the patient has no idea of any of this. They just they just go for their regular poo, and that's what they do. And what the doctor will be looking for is any polyps. Now, we touched upon polyps before, but polyps are just as important as cancers, because although not all polyps will turn into cancer, some will. And we need to be removing all of those polyps within the bowel as well.
Then a polyp is?
A polyp is a clump of cells that grows abnormally. So it looks a bit like a mushroom or like a broccoli floret or something in the bowel.
That's
It
quite
looks a bit
image.
strange. Yeah, they're quite pretty sometimes. Bit of a strange way to describe them, but they bleed.
They're pretty as a polyp.
Yeah, yes. And people, depending on how long they've been there, they can be tiny, they can be a millimetre big, or they can be up to 1 centimetre, 2 centimetres.
What causes a polyp to grow?
Do you know, we don't know the exact cause. There are lots of theories and lots of research still being done, and that question gets asked a lot, actually. It could be, so some of the things that can cause polyps are smoking. Smoking is one of the big things.
Right.
Drinking lots of alcohol, being overweight, age, poor diet, genetics play a big part in some people. So it's things like that we're like I said, we're looking out for those people with polyps as well.
How has a colonoscopy changed? Because we talk so often about different procedures in cancer, not just cancer, and any medical procedures they change and they get maybe a little bit easier, maybe less invasive. Technology improves. If we were having this conversation 15, 20 years ago, how would the actual process of a colonoscopy have changed?
So Steve, what we do now, we realise that patients need to understand every aspect of that colonoscopy and what's going to happen to them as soon as they walk in that room. I say to them, look, we have excellent doctors, but I also say to them, it's really easy for me to say that just because I think they're good and I know they're good. That patient doesn't know that. So they will come in, we listen to them. We listen to what they're worried about, and often it can be something quite minor. What they might think is minor, they might be thinking, "Look, I'm gonna feel quite undignified, and my bum will be on show, and it will all be quite hilarious and jokey." And absolutely, it's not. And I'm still shocked that people kind of worry about that sort of thing, but they do. So to reassure people, you come in, you're covered up. It's very discreet. And actually, you are the most important person in that room, and we listen to you. So if at any point you want something done, you want it to be stopped, you are very much listened to. And I would say that's the biggest change in the last 10 years. People have more of a say, much more of a say.
But has the actual technology changed at all?
Yeah, so cameras are thinner and smaller.
Sounds better to me.
It is better, and we offer more sedation and painkiller now,
Yeah.
and we're kind of more mindful that people find it uncomfortable. And I think what was accepted as uncomfortable 10 years ago is different now, and we listen to patients and think, actually, let's give you some more painkiller or more sedative.
Are you fully sedated?
No, so it's what we call conscious sedation. So
Right.
You're awake, and actually, people are quite happy to be sedated, but awake enough to see what's going on, because it's not like your average Tuesday morning. You're able to have a look inside your bowel, and it's actually quite interesting. And what we will do is talk you through what we're seeing, and patients are fascinated by it. It's just different.
I'm imagining what it must have been like. I mean, when do they go back to colonoscopies? Because I'm thinking how, camera technology has changed a lot.
I think the cameras were a lot more rigid and a lot more...
What would it have been like when they were first being done?
I think, I don't know for sure, but I would imagine they were a lot more rigid, a lot bigger. The technique wasn't there. And there's so much research and so many studies being done on how to be a better colonoscopist, that everyone's trying to be the better colonoscopist these days.
Is it painful? Because we spoke about, when we talked about mammograms in a previous episode, the guys we spoke to were very keen to point out it would be disingenuous to say that it's not painful.
Yeah.
Or it sometimes is painful. Because that's just not being realistic. Sometimes I imagine there is pain or discomfort here.
Yeah, there is some pain. And often people say to me, I'm not going to have any painkiller or sedative. And I say to them, no, you should, because actually what we have to do is we have to put some air and carbon dioxide into your bowel to inflate the wall of the bowel. And that can feel quite crampy and quite uncomfortable. and a bit gassy and a bit kind of, and people often think, oh no, I'm going to pass wind and that's going to be the worst thing ever. So yes, we do offer a painkiller, and that's we strongly suggest having the painkiller.
Yes.
And actually, what I would say is that if we give a painkiller and the patient still has pain, we definitely stop. We don't carry on, because there's no point in us making it a bad experience for you. We have to make sure that you go off and tell your friends that it was fine. So we'd either give you more painkiller or change your position and make it a better experience for you.
How long does it last for?
About 30 to 40 minutes,
Right.
depending on if polyps are found and what size they are and what procedures need to be done.
But like with mammograms and breast screening, that feels like, even if it's a bit uncomfortable or painful, it feels like a small price to pay for what potentially could be the result.
Definitely, very much so, yeah.
Do you get people who because there is a bit of a stigma around colonoscopies, do you get people who, you find something on the initial screening, and then you send a letter saying, we'd like to invite you for further tests, and at that point they go, they're not for me?
All the time, unfortunately, and that hasn't changed over the years. What I say to those patients is, I say very nicely and very gently, tell me, why did you do the test in the first place? What prompted you to do this test? Because there must be some fear that they're not telling us about that's stopping them from going forward. And it's our job to kind of tease that out and work out what could we do. Because often they're too embarrassed to say, look, I'm a bit scared of needles or something, or it could be the dignity thing. It could be something that we haven't considered. Just because as professionals we're in that room and we see it day on day, to that person it's not a regular thing. So we have to be mindful that there could be something that we're missing. But it does happen.
But so what do you do in that? Say you sent me a letter, I ignore it. Do they get another letter, another letter, another letter? Like what's the process?
No, so then we discharge the patient from the screening programme, but we make
Right.
it quite clear to them that if they change their mind in maybe 2 weeks, 2 months, 10 months, they can always come back to us. And we make sure they have our direct number to call us, because we want them to call us back. And often they do.
Yeah.
Often they've had a chat about it with a family member, or their son or daughter has nagged them into doing it. But I think we make it quite clear at the appointment that it's their choice.
Yeah.
So we can't coerce people and force them into anything, obviously. And yes, it's their choice.
Are there any other tests that they'll undergo?
Yes. So if a patient came in and weren't well enough to have a colonoscopy, because having a colonoscopy involves taking a laxative beforehand, and I should have mentioned the laxative actually. A laxative is a big deal. Probably worse than the actual colonoscopy itself, if I'm honest, because you have to fast. You have to be on a liquid diet for 24 hours before the test.
Right.
Take these sachets of laxative, gives you diarrhea.
Yeah.
But that's what we need to happen, because we need the bowel to be clean and empty and completely empty for the camera to go in and see every part of it.
Yeah.
So often that puts people off. So our job is to talk to them about that process and to make it clearer to them.
So what if somebody for one reason or another can't have such an invasive procedure as a colonoscopy, be it age, their fragility, they've got other health issues? Are there any other tests?
Yes, Steve, there is another type of test. There's a test called a CT pneumocolon. And this is for people who couldn't tolerate a laxative for a colonoscopy, people that might have poor mobility. So, for example, if you're having the laxative, you have to get to the toilet many, many times. And if someone has poor mobility, doesn't walk very well, that might be just too tiring for them. The CT pneumocolon isn't as good as a colonoscopy. It's a type of CT scan. And the patient still has to have a liquid drink the day before, but it's nowhere near as harsh as the laxative you would have for a colonoscopy. People would then go into a CT scan, lie down, and that's when the radiographer puts a very small tube into the person's bottom to put some air into the bowel. And then these very clever pictures are taken, which can demonstrate if there are any polyps or cancers within that bowel. So it's as good as, but not, no, it's not as good as, it's
almost as good
almost as good as, yes.
But best case in some cases where
Definitely, yeah.
where you can't do a colonoscopy.
Yeah. It's better than doing nothing.
Yeah, would that be for? You mentioned the laxative being quite extreme. So is that the main reason why you wouldn't be able to give someone a colonoscopy?
It is, yes. For whatever reason, some people, perhaps with kidney problems, just can't drink plenty of fluids throughout the day. Like I said, can't get to the toilet, and a laxative is just would make them unwell. And the last thing we want to do is make somebody unwell. We need to make sure we're keeping them well by doing the screening.
And is there an upper age limit for a colonoscopy?
No, there isn't.
For similar reasons, I guess, maybe.
No, there isn't. We see lots of patients in their mid-90s who are quite active, quite healthy, and if they're well enough for a colonoscopy or a CTC, we'll do the test.
Do you ever not tell people all of this? Because I imagine with me, I'm just thinking if you received a letter saying, you need some follow-up tests, I'd almost be like, right, whatever, just do your stuff. Just give me the thing to take. I don't need to know everything. Just I trust that everything you give me and everything you do to me is the right thing. You're not just doing it for your own laughs. Do you ever get people who just I don't want to know?
Do you mean about the risks?
Well, yeah, just about everything really. Because I just think almost the more you tell people, the more you might almost persuade them not to want to have it done.
I completely agree. But I think from an informed consent point of view, from a legal point of view, we have to be sure that person in front of us has the capacity to make decisions about their health. Yeah. Because, like I say, it is an invasive test, and just because we see it all day, every day, doesn't mean it's any less invasive to them. It's still very important.
Yeah. So what happens after the colonoscopy then? Say, you have your 30 to 40 minute procedure. What's next?
So after the colonoscopy, depending on what's been found during the test, so if we remove polyps, often the doctor or the nurse will talk to the patient about what they're doing. They'll describe what they're doing if they're removing a polyp. Patient doesn't feel anything at all if a polyp is removed or biopsies are taken. But whatever the result, even if we suspect there's a cancer there, we will talk to that person before they go home. Because, like I said, they're the most important person, and we have to be honest and tell you what we're thinking. We don't want any surprises, and nor do they. Yeah.
Will you generally know there and then whether there's a cancer?
Mostly, but not always. The good thing about the screening programme is, as I mentioned, polyps. Quite often we get patients who have large polyps removed, between 1 and 2 centimetres. And you think to yourself, it's just a polyp, it's great to get rid of it. But actually, when the histology comes back, it shows that there's a cancer growing within the polyp. Now, this is actually fantastic news, because this means that the cancer hasn't spread anywhere at all. It hasn't had the chance to, because there is a small focus of cancer in that polyp. So that patient will still be discussed within the colorectal team, but there'll be no follow-up required because the polyp is completely removed. And that's amazing.
Yeah, great news. Take us on to the next kind of step. Then you found cancer. Presumably there are biopsies to follow, and there's all sorts of other things to follow.
So we get the results within 7 days, and if a cancer was suspected at the day of the colonoscopy, we keep in touch with the patient because they're going to be scared. They're going to be concerned.
Would you tell them?
Yeah, we would tell them at the time. Yeah, if we're worried enough, we will tell them definitely, because they need to know. They need to kind of know what's happening and what the follow-up will be, because the follow-up will be quite rapid after that. They'll receive a call from the colorectal nurse at the hospital. They'll have scans. They'll be discussed at the MDT, the colorectal MDT meeting, and plans will be made within 1 to 2 weeks for that patient. And whether it be referral to a surgeon or an oncologist, that decision is made at the MDT decision, that meeting.
So from receiving your post screening test letter to to having a plan and having some certainty about what's going on, how long are we talking there?
We're talking, best case scenario would be 21 days, 28 days.
Okay.
Yeah.
That's good, because that's almost the worst bit about cancer, isn't it? The uncertainty between scans when you don't really know what's going on, and the scanxiety, people call it, of after certain scans. But that seems like, in the great scheme of weights, reasonably short.
Yeah, it is reasonably short. Yeah.
And I guess, as you say, you're in contact with them continually as well to reassure.
I think communication is key because, like you say, people are worried. People are at home thinking about nothing else apart from what their scan might show, apart from what their biopsies might show, and it's crucial to just maintain that contact and not lie to them, but just kind of be there for them, because they will ring up with what they think is the daftest of questions, but as long as there's someone there to listen to them and answer those questions, that's the key.
So how do we break the not taboo is the wrong word, but how do we kind of break down colonoscopies so they do sound, because people joke about them all the time, don't they? Do you hear about this? You always hear jokes about colonoscopies how do we, I guess maybe joking about them, not a bad thing. It kind of takes away some of the stigma. But how do we, get more education out there so that people understand that even if they are a bit uncomfortable, they're so important. And as I said in the previous episode, 1.6% of the people screened were invited back, but actually, of the 7 million people who were invited to take part in screening in 23-24, only 0.11%, 5,000, just over 5,000 bowel cancers were found. So, I imagine that even if you come back for a colonoscopy, chances are it's still probably nothing.
Most definitely.
So how do we kind of break down that stigma around this procedure?
I think the key for our nurses is to tease out of that person what it is that's stopping them from going ahead. Yeah. And often we find that people will say to us in clinic, yes, I'll go ahead and have a colonoscopy, and they're really polite to us. And then when they go home, they might call us and say, actually, I've changed my mind. Yeah. And we say to them, that's fine. What's really good now is we have a face-to-face appointment, because during COVID we had all telephone appointments and it was horrendous. But I think the nurse can actually build that rapport with the patient and talk to them and just reassure them and just be there and listen to them and say, this is what's going to happen. And if you talk to a patient step by step about what's going to happen when you walk into the room, it's not the fear is gone on the day, because I think when you go into a strange building, when you walk into a different room, you're not quite sure what's going to happen. Mm. But if that is explained to you beforehand, you kind of expect, what's going to happen. And also if you see the same face, so what we try to do is have the same nurse assessing the person, because the nurse will follow that patient through to the colonoscopy, and they're there by their head, they're talking to them. Yeah. And it's a reassurance. It's good.
Just going back a little bit, something just occurred to me when you were speaking there. How much can you tell from the initial screen? So are there people who you get the poo sample back and it's really like there's a red light flashing, or is it literally like yes or no to be seen again? Or what can you tell from that initial screen? So
it's yes or no from the test kit. Yeah. But actually from the screening appointment, when the nurse is asking questions about the person's health, that's when you can tell a lot about the symptoms. Right. So if a person sat there and said to me, look, I'm really having problems going to the toilet, have my bowels open. If I have my bowels open once and don't feel quite empty, that's a bit of a trigger, because you think actually there might be something there that's stopping you having your bowels open. Yeah. If they see blood but have ignored it for a few months, and we see that a lot. It's incredible how people have lots and lots of symptoms. And I think the test kit coming through the door is great for them, because they've almost waited for that to come along, because they have got symptoms. I forgot the question. I'm so sorry.
I was just kind of interested because obviously you get people who won't want the colonoscopy, but I just wondered how much of a red light you get from the screen with some people, whether you can really tell a lot from their sample, or whether it is just a kind of needs to be seen or doesn't need to be seen. Yeah, no, it's either a yes or a no, a negative, normal or abnormal result. Because the blood thing's really interesting, isn't it? Because even blood is the one that everyone knows about, but it's not. Seeing blood in your poo is not you have got bowel cancer. No, there's lots of other things that can cause that. Yeah. And many people with piles are adamant, I've got piles and there's nothing there. And it's our job to talk to them about why there might be something else there. And actually, patients after a colonoscopy will say to me, I'm so glad you reassured me enough to go ahead, because had I not done this, that 3 centimetre polyp wouldn't have been removed.
So it's great when that happens, because they know they've made the right decision. You know they've made the right decision. You just want them to go out and tell all their friends. And
if you have got a polyp, a polyp or polyps, are you more likely to get more?
Yes.
Are people
not necessarily in the same place,
Yeah.
but you definitely can develop more in the future, and we always tell people that. So if, for example, people have large polyps, or if they have multiple polyps, we bring them back in 3 years' time for another colonoscopy.
Right.
So it's in our interest to make sure that colonoscopy is a good experience for them, because they need to come back in the future. And I think it's about 15% of patients come back for surveillance colonoscopies.
Right. So, right. Do you find people who you go for one colonoscopy and that's me done for colonoscopies?
Yeah, we do. It's quite rare these days,
Yeah.
actually. Things have changed so much that it is quite rare, luckily.
If you get over the line for the first one, you've probably broken that barrier.
Yeah, and we have people coming back now recognising the doctors, and they're almost not looking forward to it. That's a bit much, but they're almost they're glad it's taking place, and it's a good thing. They realise.
We talked in the previous episode about changing attitudes to our poo, our bowel habits and things. Do you notice this with colonoscopies? Are people more willing to kind of talk about these things maybe than they were?
Yeah, very much so. Years ago, people would struggle to talk about their poo, and would come in just embarrassed and kind of, unwilling to make eye contact, and just almost like they couldn't believe they were there talking about their poo and their bowel habits. That's changed a lot now, which is great to see. And I think that's because, you hear a lot more about bowel cancer screening. And as a generation, we're growing up to just talk differently and have different discussions.
What's your advice to anyone who's been asked to attend a follow-up test as a result of their initial screen?
I would say come in and talk to us.
Yeah.
Just talking to us means nothing. You don't have to do anything. The decision is in your hands all the time, even during the colonoscopy. If you decided to change your mind and say stop, which very rarely happens. But I think just talk to us, and we can tell you, we can break it down and hopefully reassure you about what's going to happen and what's needed and why it's needed.
You don't seem too scary, Claire. I don't.
No, I'm not. I think.
I don't imagine.
I think we kind of. We're good at doing what we do. We establish that rapport, and we're able to talk to our patients quite easily. And
like we said, it's 30 or 40 minutes, but it could save your life.
Yeah, definitely.
Thank you so much, Claire.
Thank you.